microphone, but for the purposes of the fact the session is being filmed, we will use microphones. We'll have a handheld for the speakers who may want to be a bit more fluid in where they stand. And if you're asking questions, you'll find that within your table there is a microphone. You can just pull it out and you just hold the button down and speak into the microphone when you want to ask some questions. It's madness. This room doesn't really need it, but let's behave ourselves. So welcome to the session on Wellbeing and Transitions. My name is Tanya Tierney. I'm Assistant Dean in charge of Student Welfare here, so very pleased to be chairing this session. Thank you to the speakers who have come to present, and thank you to everybody else who's come to listen and hopefully contribute to discussion afterwards. We'll have 10 minutes for the presentations. I think there's a little 2-minute board that gets waved around when you have 2 minutes left. And then after that we'll have 5 minutes for questions before moving on to the next speaker. So let's make a start. I'd like to invite first Julie Chen, speaking what ethical dilemmas in clinical clerkships cause moral distress in medical students. And you can choose where you would like to be the front of the room, but please bear in mind there is a camera.
Test. Thank you very much, Tanya. I'm really happy to be here today to share a little bit of our work on ethical dilemmas in the clinical clerkships and what causes moral distress in our medical students. So I'm a family doctor by training, and I work in the Department of Family Medicine as well as medical education, and I've recently been appointed the Assistant Dean in Learner Wellbeing specifically. So our work was a collective effort, cross-disciplinary, among my colleagues who are all listed there, and because I have 10 minutes, I'm going to be very brief. Okay, so just in terms of background, I think with medical students, there are some critical times in their career where they experience transitions, and one of the key transitions is from the preclinical to the clinical years of study. And I think this is really where they get immersed into an environment that they may not be familiar with, or they have expectations that are not consistent with what they actually see. And I think as a result of this exposure and as a result of this immersion, they may experience a sense of disconnect. And the sense of disconnect can manifest as moral distress, meaning that they feel that they are exposed to something, or they encounter something that is contrary to what they actually believe, or what they've been taught, or what they've previously experienced. So this term came up in the literature probably in the 80s sometime. The first time I encountered it was with Professor Jameton, who was a professor of nursing, also philosophy. And it's really about the idea about a negative experience in which you know what the right thing to do is, but you feel powerless to actually act because of institutional constraints, essentially. And the significance is that such kind of moral distress may actually have a negative impact on patient care. So who are those that are susceptible? So in the literature, it seems that there's a lot of work that's been done on nurses and house staff. Those are probably people who have less power or less authority to do what they want to do, but actually have to implement other plans. But there's also some work done on medical students. Even though medical students may not be directly responsible for patient care, they may bear witness to such incidents, and as a result experience the moral distress. Because they are the most junior member on a team, they may lack the confidence to say something, they may have more at stake because they're being assessed, and also about lack of experience, I guess, in dealing with such incidents. So the reason for doing this study is really threefold, is that we recognize that there's the consequences of moral distress. So in particular for medical students, if they have experienced with these negative experiences and experience of moral distress, they may have some maladaptive coping mechanisms. So they may avoid, ignore, deny, suppress, and as a result, they may feel that personally distress. It may lead to psychological distress. Career choices in the literature, it says that students may gravitate away from disciplines where they might encounter these kinds of events more frequently, such as critical care medicine. And I think it's also been widely reported in the medical education literature about the progression of cynicism and decline in empathy as students go through their medical studies. So hopefully with a study like this, we can try and preempt some of these, or at least try and build resilience to deal with the inevitable exposure to these kinds of situations. There's also limited work in our own setting in Hong Kong. Most of the work that's been done has been done in Western countries. And I think the other thing is about a practical application in relooking at our ethics and humanities curriculum, where we're currently looking at the really important big ticket items like organ transplantation, about reproductive technologies, about euthanasia, so things like that, which are extremely important but might be remote for the students when they may not have to deal with those right away, and it might be more topical for them to address issues that they will definitely encounter, especially in their transition years. Okay, so the aim of our study is to identify first, as an exploratory study, looking at what kinds of situations actually lead to moral distress in medical students. So we have a 6-year undergraduate program, and through the 6 years we have a longitudinal medical ethics and humanities program that spans all 6 years. In one particular clerkship, so our year 4, halfway through, so when they're actually starting to go into the clinical curriculum, they have a 2-hour compulsory workshop in which we specifically ask them to bring in examples of situations which had made them feel uncomfortable. So here, yeah, so in our rotation 2. So they've actually had one rotation of clinical immersion in the wards, and then when they come to us in rotation 2, they will have something to report on. So we ask them to specifically use something that they have witnessed in first person, and we gave them some guidelines on the kinds of information that we would like them to report on, and then they submit it to us online. We have 2 teachers who lead this particular workshop. One is an ethicist and one is a clinician who will review the cases, and then we choose a few to discuss in these medium-sized groups according to the frequency or the interest that a particular case may have. Okay, so in terms of deciding on how we wanted the students to write up the case, we used a framework that has been reported previously, and then we sort of had a look to see what kinds of information came back to us, and then we did a retrospective qualitative analysis of the submissions. This was approved by our IRB. All of the students gave permission to do this retrospectively, and we extracted the information, we categorized them, and did our usual qualitative thematic analysis to find out what our main themes were. Okay, so of our 196 assignments, these were the most frequently occurring themes or topics that came up, and let me talk about these in a little bit of detail. Okay, so our themes, the main one that came up were situations where related to students' education. So a lot of it was students noticing that they felt a conflict when they were trying to learn with a patient or from a patient, but yet they felt that they were compromising that patient care because of their learning. The second main area was about treatment related. So this is when they were observing or involved in the care of a patient, and they felt that the care was actually not in the best interest of the patient for various reasons. Third category was about the healthcare system, mainly about resource allocation. And then the fourth one, though there were fewer that were identified compared to the other categories, I think they're very telling. So I think even having one example of poor professionalism among those who we view as role models is too many. So I just wanted to give a few examples of these. Okay, so in terms of the first theme, education and student-related matters, this is one example written by students. So these are year 4 students, once again in a 6-year curriculum. So basically, the students seem to be quite distressed about having to examine a patient who's already had some physical evidence of some injury, perhaps because of repetitive examination from her peers, and then felt that she really didn't want to add to this person's pain. Yeah. Another example, very similar, is about abdominal examination. So again, having a patient who was repeatedly examined from a group of students, and even though they were examined a lot, she was still asked to do the examination. Okay, and then about informed consent. So not sure whether or not, as a male student, though the patient had given blanket consent because they were in a teaching institution and the doctor had said that the patient had given permission, this student was not comfortable with proceeding for the reason that he states here. Another informed consent issue about an elderly man with dysuria asked to take off his trousers for a parectal, but then all the other students in the room felt very uncomfortable that they were not introduced or not sure of their role. Okay. In terms of treatment, so this is a patient who's refusing to have a feeding tube put in, but prostate consent was given by the family members. The student felt uncomfortable with that. Another one where the information about a diagnosis was given to the patient's family, but the doctor overrode what the patient's family wanted and still told the patient. So there was a complaint lodged as a result of that. The student felt uncomfortable with that. Resource allocation, so deciding who is most deserving of having treatment. And then professionalism. So I think this is quite interesting. So in Hong Kong, we have a public-private medical system, and for those who go to the public system, they're also entitled to getting drugs as part of the consultation fee, and it's a very nominal consultation fee. Okay, and I see my time is up. I'll just take a couple more seconds just to finish up. And so as a result, some patients will actually ask for more drugs even though they may not necessarily need those particular ones because they're covered. Okay, another one is about just some patient being ignored as the doctor and the team were walking past the room, and the student felt quite uncomfortable about that. And then about medical professionals chit-chatting and laughing around, even what may or may not be related to the patient care, but the fact that it was going on during a very sensitive time for a patient and their family. The student felt uncomfortable about that. Foul language by healthcare professionals towards patients. Okay, so anyway, so those are just some of the examples, and I'm not sure if it's also familiar to some of you in your own setting, but I thought it was interesting that the students did identify issues that were consistent with others that were reported in the literature, but one thing that has not been reported was about student mistreatment and student harassment by teachers. And I'm not sure if they just chose not to write about it or if it doesn't exist. I don't believe that it doesn't exist. And in fact, we're going to be looking at that particular issue specifically. And I think, in conclusion, I think that we do have a problem. I think this is something that needs to be addressed. I don't know if we can actually change a culture. It can be very daunting, but I think we can take steps. We can take baby steps. We can take every individual doing their own part. And the first part is raising awareness. And I think as an institution, identifying that this is an issue of concern and that it's important and it's a priority. And I think some of these experiences that the students have identified can also form part of a practical medical ethics curriculum. And I think that the other thing is debriefing sessions, such as the opportunity to talk about these issues in a safe environment is crucial to progressing. Okay, so on that note, thank you very much, and I apologize for going over time.
Thank you, Julie. In the interest of time, maybe we'll just take one question, if anyone has a question.
How have you started to address that?
Yes, so I was just appointed the Assistant Dean in Learner Wellbeing a month ago, and one of the things that we are doing is trying to do to get a grasp of the landscape, and we have actually convened student advisory group, so people who are volunteered to help advise us on issues that are of importance, and in addition we were going to do a widespread survey about the things that cause students stress and distress. So not just these, but the learning environment, the academic areas, examinations, teaching, those kinds of things, just to get a broader view of what is important, and then we will take steps to address each of these. So those are sort of the micro levels, but I think on a larger scale, we probably need to also come up with something very explicit, a vision, a statement, so students are aware of the things that we do consider important and that we're prioritizing it.
Okay, thank you very much.
Okay, thank you.
Okay, so let's move on to the second speaker, Laura Adams, whose talk's entitled Survival in the Workplace, Enhancing the Wellbeing of Doctors.
So, hi everyone, I'm Laura, and I'm going to talk to you about enhancing the wellbeing of doctors through a wellbeing course that, together with my colleagues Shreena and Christina Cotsius, we developed and delivered to our trainee doctors at our centre. So, just a little bit of background, we're based at a London District General Hospital, and at the time of developing this course, both myself and Shreena were working there as postgraduate teaching fellows and also medical registrars. And we were asked by the Director of Medical Education to develop some kind of resilience programme for our doctors. The initial idea for that really came from our GMC National Training Survey, which all of our training doctors in the UK are required to fill out annually. And what this highlighted was some common issues, particularly around excessive workload, stress, some discontentment with training, and kind of real burnout really for our doctors. So following that, we decided to research around this idea of resilience a bit more, and also around the challenges facing our workforce. And as we did so, I kind of realised what an important issue it is. Found some statistics suggesting that 1 in 3 doctors will suffer from some form of mental health illness at some stage, and actually 1 in 15 will form some form of alcohol and drug dependency. There's also quite high rates of attrition and burnout within the workforce as well. So, given that, we decided to set the following objectives for the course that we wanted to implement. We wanted to, through this course, really raise awareness of the challenges facing our profession, and also increase the recognition of these issues within ourselves, within our colleagues. We also wanted to provide people with evidence-based solutions to these common problems, and also signpost them to other resources and support services that are available. Obviously, with the overall aim being that we want to improve the wellbeing of our workforce. So, in terms of course development, we worked very closely with our mental health team and our alcohol liaison team. We also worked closely with the Director of Medical Education, training programme directors. We reviewed a lot of literature, and particularly around kind of recent studies about fatigue and sleep hygiene, and also the concept of mindfulness. And the London Professional Support Unit, we actually found really fantastic information and resources through that as well. But interestingly, having been a London trainee for 6 years, I hadn't heard about this until I started researching this area particularly. And actually, as we looked into this topic a bit more, we decided to move away from the term resilience. The reason for this is we found out that for some people it seems to carry a bit of a negative connotation, maybe implying to them that you're trying to tell them they just need to toughen up or cope a bit better. So instead, we decided to name our course an Adaptability and Wellbeing Toolkit. It was really vital for us that we created a safe, open environment that encouraged interaction and participation. So there was a real focus on lots of small group work, lots of exercises to try and facilitate that. We delivered the course in sessions that were between an hour to an hour and a half, and we also made the decision to take the session into pre-existing mandatory teaching slots. The reason we did that was twofold. We wanted to avoid any stigma that might be associated with people volunteering or seeking out a wellbeing course, but we also wanted to make sure that we reached everybody, regardless of their kind of self-perceived need for wellbeing support. Similarly, we provided everyone with a handbook to go away with, and this had all the information and resources, services that we mentioned in the course. And again, we wanted to avoid any stigma of somebody maybe writing down mental health support service number in front of the group or something like that, making sure everyone had all the information they might require. So our final course content included 7 topics: demands of the job, mental health, alcohol and drugs, conflict in the workplace, mindfulness, sleep hygiene, and work-life balance. We delivered the course to 37 doctors over 3 months, and the breakdown was we reached 21 foundation year 1s, 10 foundation year 2s, and 6 paediatrician trainees. The difference in that number is it really just reflects the different size of the cohorts of trainees at our hospital. We collected feedback from every delegate immediately after the course in the form of a post-course questionnaire. And in terms of key things we learned from that feedback, so the vast majority, so 81%, felt that their understanding of wellbeing improved. And actually, even those that said that they maybe knew quite a lot about the meaning of wellbeing beforehand, felt that actually, after attending the course, they felt it was a more important subject. 95% said they'd recommend it to a colleague, and actually 5% who didn't say no, they just forgot to answer that question on the form. And we also asked people to rate each of the topics according to how valuable they found it. For the vast majority, people rated all topics as finding them very, very useful. But the most popular were sleep, mindfulness, and conflict. Alcohol and drugs was rated the lowest, and when we asked people to elaborate on why, it was because they didn't find it to be personally relevant. So, for example, they didn't drink alcohol themselves or something like that. In terms of what could be improved, apart from people saying that one particular topic wasn't of personal relevance to them, overwhelmingly people just said they wanted longer sessions, they wanted more of it. We had some really fantastic positive feedback, so people felt that on the whole the course was really relevant to our profession. They liked that it gave them an opportunity for reflection. They liked that we addressed some really important issues like mental health, and they also liked that we offered practical solutions to common problems. They felt we managed to create a friendly and interactive environment, and some people actually commented that they found it was the most valuable teaching session they'd had in their year of training. People also really found benefit from talking to colleagues and finding out that actually they're going through the same thing. They have the same emotions, the demands, the stresses of the job that they feel, your colleagues are feeling them too. And overwhelmingly, people really enjoyed the mindfulness. For that topic, we downloaded an app and played it to the group, so we kind of did a practical mindfulness session with everyone, and I'd say about 50% or more had downloaded the app by the end of the session, and we're going to practice it again at home. So just in terms of our take-home messages, I think generally everyone who attended our course found it to be valuable. They like the opportunity to engage with colleagues about demands of jobs, and they like that we offered them practical solutions to common issues such as sleeping on night shifts, fatigue, etc. I think some of the more challenging topics like mental health and alcohol and drugs, whilst they didn't obviously apply to personally with everyone in the room, Shreena and I felt quite strongly that that still needed to be included. Even if we only reached one person who may have been helped by that, or even if it just means that everyone might be a little bit more likely to recognise a problem in a colleague and get them help in the future, we think that that's really of quite great value. And so just in terms of where it's going in the future, so the course is still running. We've been invited back to the paediatricians and the foundation doctors to deliver further sessions. And we're also taking it to other groups, so emergency medicine and obstetrics and gynecology. But the Trust has also appointed a junior doctor coach for pastoral care. So that will be a nice kind of addition to the wellbeing support for our doctors. We've also had some feedback that the course has kind of helped open up channels of communication between our training doctors and the postgrad centre, and made the trainees feel a bit more encouraged to engage with processes like local faculty group meetings as well. I think both myself and Shreena, through the process of developing this, feel quite passionately now about what an important subject this is. So as we move around to other hospitals to complete our training, I think we're both quite keen to take it with us and deliver it to other centres as well. And hopefully in the process we'll be able to inspire and motivate some other people about the importance of this subject. Thank you.
Okay, thank you, Laura. Okay, what questions do you have for Laura?
Your course sounds amazing. Do you have any plans to deliver it for a modified version of it at undergraduate level so that you can move kind of rescue people, aren't you? You can look for prevention if you've got this in at an earlier stage.
Yeah, I think absolutely it'd be fantastic to do that. In my current role, I'm not that involved with undergraduate training, and there was quite a divide between postgrad and undergrad teaching fellows where I worked. But I think in terms of the future, that's something I would definitely be keen to engage with. And yeah, I think you're right. I think we actually, interestingly, the poorer feedback tended to come from the more senior trainees. The foundation doctors loved it, and some of the more senior paediatricians less so. So maybe there is something about getting in early with people.
I think we tend to include wellbeing, for example, comes through our counselling service. That's where it's offered rather than being embedded in the curriculum. So that's maybe why students don't feel that they need something that comes through a counselling service. Actually, I think, as you said, it's really important.
And just highlighting through the course, highlighting to people all the services that are available for them. As I said, until I researched this, I didn't realise. I think it's important as well.
Any further questions? Can I ask about the practicality of running it in terms of manpower and resources? What's that like?
So it was just me and Shreena who ran it. We spent a long time researching it and working with other people to get all the information we needed, and that took a lot of our time. But in terms of actually going in and delivering the sessions, it was just us. I think we would have been quite keen to bring in some external speakers, maybe from mental health team or people who are good at doing mindfulness or something like that. But because we went into the mandatory sessions, we had very limited time to do it in. I think if we could make the sessions longer, then it would be great to involve other people.
Sorry, I may have missed it, but you said the sessions were short, but how many sessions in total? What was the total contact time?
So we just did an hour and a half with each, with hour and a half with F1s, hour and a half with F2s, hour and a half with paediatricians.
people that proceed in the long term actually helps adaptability.
Yeah, we should do, shouldn't we? Maybe I'll send out another questionnaire.
Yeah. Okay, thank you, Laura. Let's move on to the third speaker. So, Bronwen. So this talk is improving student transition to clinical settings using clinical classroom format.
Hi, I'm Dr. Bronwen. I'm a Senior Lecturer of Medical Education at Western Sydney University. It's really great to follow those two talks because they highlight some of the things that I want to highlight, but I don't have to talk about them as much, so I'll move on. So in 2016, one of my colleagues completed a systematic review trying to identify factors that impacted on preparedness for clinical clerkships. So they were looking at that transition from preclinical to clinical, and what were the factors that students perceived helped them to be more prepared. And of course, there were certainly points that could be applied to the actual clerkship stage, so to have clinical skills refreshed, to have better clarification of roles and expectations, to demystify some of the healthcare hierarchy and assessment processes. But then there were a few dot points that they came up with after that systematic review, which applied to the area that I could actually influence, which is the preclinical teaching. So my focus, I'm a scientist by background, so my focus is the foundations of medicine and the scientific basis of medicine. And we identified that we could perhaps further opportunities for the students to apply some of that scientific basis of medicine to more clinical cases. So that's what we did. So in our course, it's an undergraduate medical degree, that's 5 years long. We have at the end of year two, two topics, which are infectious diseases and oncology. And they're a great area to start applying student knowledge to more clinical cases because they cover multiple systems, so they're not just respiratory or cardiovascular. And they also start to address some of the areas that the students will be covering when they get into year three, which is they do attachments in medicine and surgery and also community medicine. So it was a great time to start implementing this course design. We have a PBL-based program normally, so students are very used to small group teaching. They have 4 hours a week in PBL, but the problem with PBL is it usually focuses only on one case. The students only get to practice applying their knowledge in problem solving to one case per week. And they also are facilitated by PBL tutors who aren't normally content experts, so if they do come across something tricky about the clinical scenario, the PBL tutors can't always answer their questions. So we decided to create these blocks of teaching called clinical classrooms. There were 1 hour tutorials once a week for the last 8 weeks of the course. And they covered those topics that you can see. There were 6 infectious diseases clinical classrooms and 2 oncology clinical classrooms. The infectious disease classrooms have been running for the last 5 years, and the oncology ones we just introduced this year. So basically we adapted a team-based learning, a very, very modified team-based learning approach for the clinical classrooms. I was lucky enough to come to NTU 5 years ago when TBL was being set up for this medical school, and to be involved in some of the discussions and be really motivated and inspired by some of the things that were happening here. I couldn't take all of that back with me to Western Sydney because we're a PBL-based program and we don't have the facilities to do TBL, but we certainly could take some of the inspiration for our clinical classrooms where I thought it really applied. So instead of live lectures, we put our lectures in smaller modules, smaller videos rather than 50-minute lectures. We got the students to do those online, and we got them to set an individual readiness assessment so that they could show us that they were prepared to come to the clinical classroom. So that was all online. Then they came to a face-to-face session where they were allowed to choose their own team and a team leader, and then together they sat the team readiness assessment or quiz to show that the whole team was on the same page in terms of their knowledge and preparedness to approach the content. Then we gave them approximately 4 to 5 case studies to answer. There was a combination of multiple choice and also short answer questions. And then there was there were a team of a scientist and a clinician and a few other people roaming around to answer questions. So this is basically what it looks like this year, and probably will for the next few iterations. But it was actually quite a process of engaging the content experts, engaging the teachers in understanding what it was we were trying to achieve, and to get it to the stage that we are at now. So when I started in 2014, the content expert really wanted to use Nearpod as the e-learning tool to run the clinical classroom. We only had a lecture for our venue, which is terrible for group work, and we were trying this TBL approach, but in reality, a lecture theatre is not a place to do group work, and the students weren't that thrilled. The following year, having been to NTU and seen how they used LAMS as a software to run their team-based learning, we moved to LAMS, and we're still stuck in the lecture theatre, unfortunately, but it was a small improvement in terms of the student engagement. Oh, sorry. This shows you that you can have a good idea pedagogically, but you do need to keep on going at it and going back over what you can and can't do. The iterations really make a difference to how the product ends up. So 2016, we had feedback from the students that they'd really like to do all the group work by themselves in their own time and then come back for a wrap-up session. And that was what they wanted. They didn't want to have to do all the group work at the time that we just told them to do it. And so we said, okay, we'll give it a go. And we actually let them do the group work self-paced. And that was the worst feedback for the clinical classroom that we had that year. So it actually followed the students' requests, and it ended up being really a disliked component of our course. So we went back to compulsory sessions. We used a combination of Blackboard to deliver the lectures and LAMS to deliver the TBL. And then finally this year we had everything seamlessly in LAMS. We have small group teaching in a small group area. The content experts understand that they needed to divide up the lecture into 2 sessions. We don't have a room big enough for the whole cohort to sit there at once, so we do it in 2 sessions, and the content experts acknowledge that they just have to spend twice the amount of time being available. We had brought in new experts, and it just had a really great feel this year, so the final iteration has really paid off. And just to show you an example of student feedback, from 2015, the students were asked, did the online lectures and the individual readiness assessment help them to prepare for the clinical classrooms? And it was pretty much mediocre. No, I didn't really. Yeah, it helped a bit. Agree and disagree. Neither disagree. We're all in the below 50%. But as we've improved everything, we've had a really remarkable upturn in student satisfaction. That yes, they were feeling much more prepared and ready to engage in the content. We also tidied up some of the questions. We discovered that our content expert had written some questions that weren't answered in his lectures, which of course made everybody feel very dissatisfied. So yeah, you got to keep cleaning that stuff up. The student feedback for team discussions. So we had, again, 2016 took a nosedive in terms of how they agreed that the actual group work helped them to engage with the content. But as we improved both the location of where we do it and the software, the students are 90% agreeing that this is a really helpful way for them to engage in the content. And also similarly, that they feel much more confident to solve clinical problems in these topics. So having a go at solving multiple cases and talking to the content experts in the room, they're feeling much more confident that they can go into the clinical years and start to see real patients and know how to apply their knowledge. So just a little bit of the student feedback. Of course, I've picked all the really nice quotes, but the ones in the black boxes are from the infectious disease clinical classrooms, and the red ones are from this oncology topics. And yeah, so generally they thought it was really helpful. It was a really way to revise and consolidate their learning. They really liked the teachers being interactive and encouraging. One student really wanted a more competitive system, so this is not assessed. And so really the students, it's just compulsory, but they don't get any marks. But we had a feature this year where they got a score at the end of each session. I think that's a new feature in LAMS. And that actually generated a lot of excitement where they could walk out and say, yay, I got, my time's up. Yeah, I got 100% in that question, and they could walk and say it loudly and make sure everybody could hear them. So simple things like that made it work really well. And so I've got a couple of minutes for questions.
Thank you. What questions do you have for Bronwen? Come on.
Have you managed to convince the staff then to switch from PBL to a more TBL-based learning system?
They don't know it's TBL because we keep calling it clinical classrooms, and also I hesitate to call it TBL because I know the TBL purists out there would not think what I'm doing is real TBL. But yes, we've certainly seen the value in adding, so it's a flipped classroom approach to what they do. So the PBL really helps the students to draw out what are the learning outcomes that they need to be researching, and the TBL is helping, or the clinical classroom is helping them to actually check that they, at the end of the learning, that they got where they needed to get. So I think at the moment, I think we like both rather than one or the other.
Get any pushback from staff just because it's a lot of development time often to do that, and it's much easier to stand at the front and talk about something you know a lot about for an hour than it is to actually develop what you do.
The way I sold it to my first content expert was he was doing 13 hours of teaching, that once he recorded all of it, then he wouldn't have to do those 13 hours anymore. He could just come waltz in and walk around, and he really liked that. Unfortunately, he liked to take notes of all the time it took him to develop content, and he told everybody how long it took him, and it did put some people off, but I think they're starting to see the results now, and oncology definitely came on board. They were really committed, and they did it quite quickly. So, but yeah, the payoff was if you record the lectures, and you don't have to give them every year, so you free yourself up by the teaching. Yeah.
But you don't make them redundant,
No.
You were saying the intention was to help students feel prepared for the clinical years, and obviously the feedback showed that the students feel more prepared. Have you noticed any changes in the students' behaviours or their performance in the clinical space?
I think that's the next thing to do. I think it's taken us a while to get the actual clinical classroom to a level that we feel that we're delivering what we wanted to, and the students are understanding what we're doing. And now, yes, the plan is to look at their assessment to see that those infectious diseases and oncology assessment is improving, like in their exams, that they're retaining that knowledge. And then it would be great to just do a survey as well and just say, does this help you or not? I know it's a very small part of what will help them feel better. And I'm not saying I've got the solution, because I know that it's a really complex transition, but it's one small part that I could at least influence.
Thank you. Any final questions? Okay, let's move on. So our next speaker is Lucy Rosby, the role of peer group in medical student transition from classroom to clinical learning environment.
Good afternoon, everyone. It's really great to be in a forum today where we're all talking about transition and wellbeing in some way. Whenever I've shared some of this before, it's been in slightly different, more varied groups, so it's really great to be able to share with everyone who's been doing similar things. So my name's Lucy. I'm a senior lecturer here at LKC Medicine, so I'm on home territory today. And I'd like to share with you the results of a study we did. Actually, it was a couple of years ago now. But it was looking at the role of the peer group really in medical student transition, so I'll take you through that. So I won't dwell on this because I think we've talked about it quite a lot, but really our study was looking at the very stressful transition between classroom-based learning for our medical students into the clinical immersion of clinical placements. And as we've all discussed today, it's been well acknowledged that this is a very stressful period for medical students, probably the most stressful during medical school, outside of becoming a doctor and making that jump. So from the point of view of our context, LKC Medicine, as you are probably all aware, is a relatively new school. We opened our doors in 2013, and we are an integrated curriculum with systems-based. And when our first cohort were moving into year 3, so from the second year in the classroom into the clinical immersion into year 3, we thought it would be a really good opportunity to find out about how that transition went for them. And to be honest, unique as well, because they were a group with no one to follow. So although we have other medical students in Singapore, they didn't have any peers from our school to follow, to pass notes down, give them the information about which people to talk to on the wards, to give them tips and tricks of how to survive. And so, you know, they were bravely taking those steps on their own. And so we thought this was a very good opportunity to sort of find out about their transition. And the students actually were all based in one hospital. That's not the case now, but in this particular year group, they were all based in one hospital and did postings in medicine, surgery, and then other short postings. So what did we do? We actually had quite a unique method. It was a largely qualitative study, and we decided to define the transition period as the first 2 weeks of the students entering the clinical placements. Now, appreciate that I think a transition period is probably different for every student, and it's difficult to be quite so prescriptive about it, but we really wanted to capture the students' experiences when they first hit the ground, when they were first sort of trying to find their way to the wards, trying to work out how to navigate this new environment. And so we decided to collect our data in those first 2 weeks. We had a half of our cohort of 54 volunteer for the study, and a large proportion of data collection was around photo elicitation, which is a method whereby you ask participants to submit photographs with captions and titles. So we asked our students to submit 2 photographs per day during their first week on the wards. And we directed them a little bit. We asked them to submit a challenging and a positive experience each day if they could, with some reflections and a title. And then the following week, we interviewed all 27 to discuss their experiences on the wards, but also explore their photographs a little bit more and get some more insights into what they had sent in to us. And the team also had some opportunities to observe the students during those 2 weeks, so we followed them on ward rounds and into clinics and so on. And this was more of a contextual thing, because apart from myself, most of our team, one of whom is actually here today, were social scientists, and so giving everyone that contextual information was quite important. So results-wise, we had a total of 162 photographs submitted by the students during that week. Some students didn't submit anything, and others submitted the 2 per day, so a total of 10. So we had lots and lots of data, and our interviews averaged around 40 minutes. So we did some thematic analysis. We also laid the photographs out on a really long table with all of their captions, and did a content analysis of those photographs to draw out some of our themes. And we did have a number of themes, but probably the most important theme and the most dominant theme, which I'll take you through today, was looking at the role of the peer group in that transition experience. And I'll also take you through the sub-themes that came out of that as well, using a few examples of photographs and their captions that were submitted. So the first one is probably the most expected, was the idea that students use their peers to learn together. So when they're trying to navigate and get themselves around the clinical environment, finding opportunities for learning, they generally go with somebody else or in a small group of maybe 3 or 4. And so we had lots of things submitted similar to this, with an image perhaps representing the environment they were in, and then a caption sort of indicating that there was at least more than one of them. So here we found the opportunity to observe 2 surgeries, so 2 people going off together. And then in the second one, they're off to take a history for the first time, and rather than going on their own, my partner and I took a history for the first time from a real patient. So we saw lots of this coming through. On a slightly different note, there was also an awful lot of data that came in around students using their peers from an emotional support point of view and requiring that sort of social network to get them through. And this first one you can see here with the bag on top of a set of lockers, we actually explored with the student an interview, and he was in a clinic until a very late time of day. And when he got out of clinic, he had a WhatsApp picture, which was this one here, from one of his friends who was really concerned that he was still in clinic at nearly 7 o'clock in the evening. And he was really touched that someone had thought of him in that way. And then just to add insult to injury, he was locked into the hospital because it was so late and had to call a friend who helped him to guide him out of the hospital. So there's a lot of gratitude in his exploration and interview that is also documented here, as you can see. So that was a lot of emotional support for this particular student. And then on the other side, sort of support from peers in learning. The second one you can see standing in theatre and as well as Googling and teaching one another the scraps of info we know, so sort of gathering information and sharing to sort of bring everything together. The third sub-theme, which we termed normative comparison, maybe not immediately obvious what that means, is about how the students use each other to gauge their own progress within maybe that small group that they're on the ward with. So some of them were documenting that they knew they were doing okay because they were all kind of doing about the same. Others felt that they were falling behind their peers. As you can see, this first image here is clearly someone who feels quite isolated and different to the rest of their colleagues, and talks about how when my team talked about our weeks, I became aware of how many opportunities others had to practice different technical skills. Unlike the others in my team, it seems like I'm the one lacking hands-on practice. So this fear of everyone else around me is just doing X, Y, and Z, and I'm not getting those opportunities. Am I falling behind? Then on the flip side, we also saw students who actually felt they were doing better than their colleagues and they were getting more opportunities. I don't feel nearly as lost as many of my friends from other teams, and I'm truly grateful to have had a good beginning. And so there's this sense that they can use their peer group to sort of gauge their own progress and perhaps accelerate or decelerate their learning accordingly. And then finally, this sub-theme of shared pain, which is sort of, in a way, it's a nice idea, but there's also a sense of sadness in me around this one, because it's this idea that in moving into the clinical setting, there's a real sense of resignation and acceptance around certain things that are going to happen. So, for example, this particular student, it dawned upon me that on many days we enter the hospital before sunrise and leave after the sun sets. And there was lots of things that came out in an interview around this, around students kind of just saying, well, we're all in this together, it's just the way it is now. My life is over, I'm in clinical medicine, that's it. I'm wedded to the hospital sort of feeling. And a similar sort of thing here, we complete our ward rounds, but our day is not over without revising what we have learnt and preparing for the next day's work. So this sort of sense of resignation that there's this new lifestyle that they're having to embrace. But the positive side to that is that because they're all in it together, there's this sort of sense of collective difficulty and this sense of, we can do this, we're coping with this as a group, we've got friends who are going through the same thing, so I'm not on my own. So this real sense of needing to utilise your peer group as someone who can support you. So I suppose the key messages that came out from this particular part of the study was that clinical learning rarely happens alone. And I think we know this not just within the transition, but in general. I mean, we all learn lots together within the clinical environment, within the teams that we work in. But we see that students draw on their peer groups for support in a number of ways, whether it's practical level of working, finding patients to go and see, working out which are the best consultants to get your teaching from, to the emotional support from your social group. But they also use their peer group in a way to measure how well they're doing, to get a sense of how they are progressing in this new environment. And I think, as I've just mentioned, there is this sense of if they're together in something, that it eases that adjustment in some way. That it's normal to feel the things that they're feeling and to be struggling perhaps with some of the things that they're struggling with. But I think one of the things that I felt was quite important as well was that if the peer group is that important for the students to make a successful transition and to be able to successfully progress through that year, then what about those students who are a bit shyer or who are less willing to ask for help from their colleagues? How do we support those students from a welfare perspective as they transition into that environment? Because it's clearly going to be a lot harder for them. So that was just something which I felt was an important point also to take away.
Okay, so what questions do you have for Lucy?
I've never heard of both Elicitation, so Well, absolutely fantastic. And we've on one of the courses we're running in Imperial in London, and we have tried to get students to submit photos, but we've had to incentivise it to encourage participation. So I was wondering how you might get such high levels of participation.
That's a good question. I think so. This was our inaugural cohort, so I think this has a lot to do with it. In a way, they are a very enthusiastic, driven, hard-working group, and obviously all medical students are hard-working. But this particular group were very unique. You know, they were brave to come to a new medical school, and they were really driven to sort of be that pioneer group. So I think when we approached them to participate in the study, I think there's a lot of enthusiasm around it from that perspective. Having said that, we have done subsequent studies with other groups of students here, and we are quite fortunate, I think, that students are generally quite keen to take part in things. So I don't know whether it's Singapore or whether it's just that we're very fortunate with our students here. But, yeah. Yes, exactly.
What I really liked about this was that you started talking about a stressful transition, but your approach was to get students to talk about positive things and present positive images. And do you think that's something we can do more broadly? Sometimes I think when we're thinking about well-being and welfare, we go looking for problems, and we ask students, you know, please tell us about your health issues and your family problems and all that sort of thing. And do we need to do more in actually looking for positive messages to actually get students thinking about what's good about you, what's good about them?
Actually, yes, I think so. I think even beyond the transition, and like you said, looking more at well-being and into the postgraduate arena as well, there is so much negativity out there around that. That's all that's ever publicised. That's all we ever hear about. So I think that's a really important point. And even when focusing particularly on the transition that I've talked about just now, that students have a lot of anxiety, so we tend to focus on what those anxieties are and how we can solve them, rather than all the really great things that are going to come out of this new experience in this new environment. So as part of that support for students moving into year 3 or whatever year it is of your curriculum, I think perhaps we could do more to emphasise all the other things that are going to come from it too.
I haven't quite articulated this thought, but it's something about the law of diminishing returns. In other words, if you look at, this is a UK experience, if you look at student satisfaction in most medical schools, it's pretty high when they're bundled up at 90% level of satisfaction. And in many ways, schools are making huge efforts to improve experience. But as that rises, the satisfaction once they go into work plummets rapidly. And in fact, now we're seeing ever increasing numbers of students leave the system after about 2 years. Perhaps we don't know how long is going on. So while we're dealing with the immediate problem, the next bit seems to be completely disconnected. So we're preparing them we prepare them in an environment where we're very supportive, and then we chuck them into an environment where there is no support. And in a sense, I'm not sure we've prepared them for the reality. So I mean, that's just the thoughts that are going to be raised.
I have to say, I think it's an interesting point, and I think it's a good one. And it just made me think there that of a conversation I had recently along a similar lines, actually, but in the Singapore context. And in our context, we have a very strong welfare and support network for our students because we have a house system for them. So they're all put into a house. This is one of Tanya's babies. And they're all put into a house, and they have a very strong community across the 5 years. And so, again, we are nurturing and nurturing and nurturing, and then obviously, like you say, they reach the big wide world, and it can actually be very different. I don't know how you avoid that, other than reducing the satisfaction of their learning during medical school. I'm not really sure.
Any final questions? Okay, all right. So let's move on. Moving on to Kevin Murphy. Challenges of transition from school to medical school for students from underrepresented groups.
Okay. Thank you very much.
feel like I should be on a rotating podium in the centre, but we'll stick in this corner and see what happens. Talking with the other
Whilst we're dealing with the technical hitches, if I can just invite people, so within the app there is a discussion wall. We have student representatives who are going to start discussions, so it's healthy discussion between the talks here, but there is also a forum within the conference app that you can comment on the presentation, so please do feel free to continue the conversation there. And now Kevin's going to sing a song.
So I guess to say the slide or two, so my name's Kevin Murphy, so I'm a professor at Imperial College, and one of my responsibilities is the admissions tutor for widening participation. And widening participation, for those of you who aren't familiar with it, can be defined in different ways, but essentially I guess what we're trying to do is to get people in from less typical backgrounds into medicine, so into medical school and out into working as doctors as well. And we've been doing a bit of research looking, I guess, at people's perceptions from different backgrounds before they get into medical school of the challenges of medical school and of the challenges of being a doctor and how they're perceived by different groups within that. And I'm hoping the slides will back me up because I can't actually remember everything. Okay, so we've said all that. And I won't bother defining widening participation. So why do we need to widen participation? You don't really need to understand much of the details of this. This is basically showing, there's no laser. Basically showing that people from low participation neighbourhoods, which you would expect to be about 20% of people, actually fewer than 5% of people from those backgrounds are getting into sort of medicine and dentistry. If we're looking at people from lower socioeconomic classes, what in the UK would have been thought of as the working class in the past, which maybe is about 35% of people, actually less than half of that number are getting into study medicine. And we could say, well, it's hard to get into medicine, there's lots of advantages, but if you actually look at other things, train for professions like law, or if you look at the other sciences, or probably the worst art subject is historical and philosophical studies, and they still outgun medicine. They still do a lot better at being representative of the population. And I guess actually it's more of a problem for medicine in many ways as well, because actually in historical and philosophical studies, you're not dealing with the public, and you're not dealing with all the social classes and people from different backgrounds on a daily basis. But the idea is hopefully that your population of medics to some degree represents the population that they're serving as well. So I guess in the UK, so synonymous is doctoring with a kind of upper middle class demographic that there's actually a series of romantic novels based on the idea of posh docs. In the interest of research, I wrote the first chapter of the Greek children's doctor, and I can confirm that it's the doctor that's Greek and not the children, and also that the demographic they're aiming for, I think, probably would not understand the term paediatrician, hence the Greek children's doctor. So the idea of widening participation is hopefully we can increase participation in medicine of students from more disadvantaged or less represented communities. And the idea is that hopefully your social background doesn't inhibit your access to medicine. And we have to be realistic about this because actually that is not the case at the minute, and we're making lots of efforts to try and reduce the effect of social background. We did a bit of work a few years ago at Imperial, again you don't have to worry about the details, which showed that actually what we need is kind of sustained support for people from less represented backgrounds. It doesn't help just to go in and give them a talk about something necessarily. It doesn't hurt, but actually where you see real differences is where you get people on sustained programs. So we have a program called Pathways to Medicine,
that is co-funded by the Sutton Trust, which is a social mobility charity, and we take people on for the last 2 years of school, basically, where they visit us multiple times, and we sell out work experience for them. We give them some training in interviews and entrance exams and things like that. We run a summer school, and that's me proving essentially that I don't just talk about it, I actually do something in the summer school, though what exactly I'm doing with my invisible pipette in that, and my elbow seemingly bending the wrong way. I'm not exactly sure. But they enjoy it. From the numbers we've seen, it does help people get into medicine. So from that demographic, we have about 60 kids a year on it. From the numbers we've seen, probably between about 10 and 20 get into medicine every year, which from that demographic is not bad. But it's quite labour and cost intensive, essentially. So you can only help a small number of people with that kind of thing. So we're also looking at things we can do outside of these kind of things. So we're looking at how people think about transitioning to a career in medicine and what kind of tools we could put in place to help people that might be available on a wider basis. So often people talk about different phases of careers, you know, this self-assessment, do people want to be a doctor, do they have the skills they need, what are the options, then if they decide that's what they want to go for, what kind of course do they want to do, and then how can they maximise their chances of getting in. And I think we're quite good at some bits of this, and we're not good at other bits of it, and we've done a bit of research which I hope casts some lights on the bits we could improve. So I'm not going to go through the methodology in a huge detail. Essentially what I'm going to talk about is summarising. We've done a number of one-to-one interviews with current students from different backgrounds. We've done a series of focus groups from different types of schools, so publicly funded schools, which are generally more under-resourced, versus privately funded schools, selective schools and non-selective. We've also done a series of questionnaires, so we got about 1,400 responses from kids from different types of schools who are doing the subjects that could get them into medicine, but not all of them are going to go into medicine, and so we asked them a bit about the reasons why they would or they wouldn't go into it and so on. Some of them even finished the questionnaire, so out of about 1,400, about 1,000 of them finished it. And the idea is that hopefully we're going to use these findings to come up with some kind of toolkit and to provide guidance for how we can further support people at school level, and I guess when they come into medical school as well. And so if you look at the sort of thematic analysis of the stuff we've been picking up, so sort of general themes are information, advice and guidance, I guess learning about university and the admissions process. Work experience is a big factor because in the UK, virtually all medical schools require some medically relevant work experience. Support and networks, that's before they apply, but also when they're at medical school as well. And perhaps unsurprisingly, finance is quite a big issue for them as well. So we also asked a lot of them what puts them off doing medicine, so people who decided not to go into medicine. And I think talking about, relating some of the other talks we've heard today, so in the UK, the current state of the health service with the recent junior doctor strikes and the morale of staff is actually a bigger factor than I would have anticipated for a lot of sixth formers. So one of the quotes there is actual brutal, honest comments you get from people who are working in the front line. It's obviously high grades and other requirements outside of those grades as well. And when they say it's competitive and challenging, they don't just mean that it's competitive and challenging to get in. A lot of what puts some of these kids off is that they see it as a competitive and challenging and a slightly alpha environment that they don't necessarily want to be involved in when they get to medical school. A lot of them said they think it's too early. They think that they've got to, obviously they're coming in at 18, but actually to get all the prep ready, they're deciding at 15 or 16 to do this. And they feel it's really early to decide to do this thing for the rest of their life. They talked a bit about mental health and wellbeing concerns, which I think is much more of a factor than it was for my generation, people actually being aware of it and quite worried about it in the future. For the ones who are poorer, the fact that it's a long course has real financial implications for them, so they're very worried, the fact that they're going to be paying tuition for a long time. And there's concerns about the long hours and the stress. And actually you see a lot of them, again, are much more forward-thinking than I would have been at that age, but they think about, in the future, am I going to be able to have a family and look after it if I'm doing all these long hours? From the questionnaire as well, we got some other, so I regularly pass out at the sight of blood, which was one of my favourites, for the reason I didn't want to be a doctor. And this one we couldn't really follow up because it's a questionnaire, I despise doctors. Not typical of all 1,400 responses. So if we look at the kind of information people have access to, So at people from poorer schools, essentially, they say it's really difficult to navigate. All the medical schools are different. There isn't a kind of single site where they can get all the information they want, that it's really difficult to compare between medical schools because of that. They say that they often choose their A-levels because they enjoy them or they think they're going to do well at them, and actually it's only when they get into sixth form that they realise that in fact they needed to be thinking about their career and their university choice earlier than they had been. We talk a lot about we would like you to come to us because we have a certain style of teaching, we do PBL, or we have this particular curriculum, and they say we have absolutely no experience of any of these things, and how are we supposed to decide based on that without exposure to them? And they talk a lot about motivation and perseverance, actually. And what you find, actually, is the ones that have decided to go into medicine actually talk a lot about that that's their quality that pushes them forward, that they're coming up against these things and getting over it, and they think it'll be useful. And you get that a lot less from the more supported schools, actually. So they tended to have got careers advice at an earlier stage. They'd often done work experience earlier, and they felt they were just supported in their decision making by the school, and also I think just by personal contacts who are more likely to be in the professions. So if you look at work experience, as I say, a lot of them found it really stressful because by the time they realised they needed it, they had to fit it in short term in order to get their applications in. They talked a lot about luck in finding placements, and actually if you talk to them it wasn't luck, because the people who from these non-selective schools were people who'd sent emails to 200 people, and they said they were lucky to get it, and they kind of made their own luck. But of course we're not asking everybody to send 200 emails, it's just the people without contacts and without the networks and the access to those networks, I guess. And he also talked about the fact that they couldn't afford certain volunteering opportunities abroad, which they thought that other kids could. And as I say, pupils we talked to at independent schools much more likely to have already done work experience when we spoke to them, pushed by the school much earlier, and their parents were a big influence as well, always pushing them to try and get this under their belt early on. So I guess one of the helpful things I think about the work experience is that we push work experience and we say you need to do it to see if medicine's right for you. But students actually see it as something that they've got to do, that it's a hoop we're making them jump through. They don't always see the relevance of it. They just think, God, it's something else I've got to do, until they actually do it. And then actually what we got from a lot of them was actually they saw that work experience was important and it helped them make up their own mind. So I think that is kind of helpful, and I do think work experience is really important, but I do think we need to think about how people get access to it and how we can equalise people's access to it. So in terms of support and different networks, so a lot of school students talked about medical societies in their school. Again, that happens much more at selective schools, at private schools, that they organise themselves into medical societies. And they said it was really useful with kind of past pupils coming back and sharing their applications and their experiences. There was the thought of not being able to afford training opportunities for things like entrance exams and so on. There's actually not much evidence paying for that training actually makes that much of a difference. It's much more to do with how much work people put into them, but it's still felt that it's unfair, and that's slightly corrosive to the system. I think that people feel you can buy your way in a bit. They also mentioned a lot, the current students we talked to, they talked about a lot of support from societies within the medical schools, the medical school they were in, and how that was really helpful in getting them through things. And they talked a lot about how you had to be so prepared for this transition to university. And then finally, finance. I mean, again, it's probably not surprising if you're from a lower socioeconomic group that you're very focused on the cost of higher education. I think maybe I've not realised quite how much. And the thing is, in the UK, your tuition is free at point of entry. You pay it back later when you're earning a certain amount. But that kind of financial burden seems a lot greater if you're from a lower socioeconomic class, I think. We found a lot of them are working in sixth form anyway, but a lot of them are working in sixth form to save money for university, or they're taking a gap year to save money rather than get more experience or anything. They were deciding on the universities based on where was the cheapest place to live rather than on the course that they wanted to do. And they were really concerned about, like pre-entry materials, the courses they needed to go on in the books, but also about how they were going to survive as a university student, and not just accommodation, what the course was going to cost them in terms of things that they needed to do while they were there. Interestingly, from richer families, they also had concerns. I guess what they were saying is they didn't qualify for a lot of the schemes we had in place to support underrepresented students, but they were also saying if you didn't happen to have the contacts, even if you had more money, it's very difficult to buy your way into work experience. So if you turned out to be well off and a good skill but didn't have contacts, which was less likely, but you still didn't have a way of transforming your money into experience in a way. So some of them felt they were in a sort of a difficult middle zone. So in terms of the challenges, so essentially publicly funded schools came out as least able to support their students. They had less students that had gone through it. They had much more churn of staff. The application process is difficult. They have less money invested in career service. The prevalence of money in networks really eases the application process. Students don't really understand what university is like, particularly if they don't have siblings or not many people in their school are coming back to talk about it. The culture of medical school can seem quite off-putting to a lot of them, and medicine doesn't necessarily seem that appealing to a lot of very bright, able students as well. And when they were at medical students, some of these students from less well-represented backgrounds also didn't feel that they belonged in the same way, that they felt there was a kind of cultural demographic that they weren't fitting into, which wasn't all of them, but some of them. But I think, as I say, that I think the most difficult thing is the sense that the process is unfair, that you can buy your way in, and I think we try and limit that, but I think we can't ignore the fact that from certain socioeconomic backgrounds it is easier to jump through the hoops that we put in place. We asked them what we thought would help prepare students for university, and they talked a lot about talking to undergraduates, more practice of having to study independently and exposure to a university lifestyle and I guess teaching as well. And also they wanted universities to appreciate that it was quite difficult actually to settle into university, to make that change, that emotionally it was quite difficult for a lot of them. So they said that, and I think part of what we've come to with the tuition fees and the competition for students is that a lot of them say, well, universities tell you the good side and they're trying to get you in, but they don't tell you about the more difficult aspects all the time of what it's actually like being at university. And as I say, they feel quite young to be making these decisions. So what should we do? I don't really have the answers to that, I should point out. I would say that we're currently focused on bringing underrepresented students up to a competitive level, but maybe we need to think of how we can do better by these students rather than just saying, okay, you need to get over this hurdle, we're going to help you over it. Maybe we need to think about the hurdles that we're setting. Do we think those we select make the best doctors? Could we change our requirements for underrepresented candidates? Are we asking a lot of the time for skills and experiences that we could teach? Can we give students a better idea of what it's like to be at university, and can we provide better emotional and I guess mental health, and we've talked a lot about it earlier in the session, and maybe financial support as well. I think I probably can't answer whether medicine should be a postgraduate subject exclusively in the UK, but there's certainly a lot of discussion around it. But I guess also going back to the talks earlier, I think there is a real perception that medicine as a career is very difficult, and in talking about even if you get a lot of support at university, you have to go out into this world where you're going to be quite hard, worked quite hard, where there's going to be a lot of pressure on you, and that does seem to be putting a lot of people off. The good news, this is the current Secretary for Health in the UK, as you can see. I think he's on top of the job. You can see him here bothering an old person, pushing an invisible car across a dance floor. So I think it's all in good hands now, and the culture should be transformed overnight. Obviously, I did all this work myself, and all these people asked me if I wanted a cup of tea every once in a while. We're supported by the Sutton Trust, by various societies in Meru, but Amandit Bissell is the PhD student who's done an awful lot of this research, and so it should be her up here rather than me, but I get to travel to Singapore, it's not all bad news. Thank you very much.
Okay, what questions do you have for Kevin?
Thanks, that was really interesting. I actually, I suppose, a couple of comments. First of all, last year we ran a widening participation course at my local hospital. We kind of invited schools from a kind of a catchment area, and it was a 2-day course, and we ran it for free. And the response was amazing. We had a waiting list as long as our arm. Unfortunately, we couldn't kind of facilitate everybody, we had about 35% of people who attended were on free school meals. I was quite surprised when we were researching the course. There are so many of these how to get into medicine courses, and they cost a fortune. People are charging hundreds of pounds, and people pay for it. But I think just your comment about public schools not being able to necessarily support their students and things as well. I actually got contacted by quite a few of the schools that we invited through their careers or their heads of department, asking if we could run a course for their teachers to help support their students. And unfortunately that wasn't really something we were able to do at the time, but maybe that would be an interesting another bit of work or area to go down is helping the schools.
Yeah, no, I think that is really helpful, because then as well, there's a lot of turnover of teachers in London, but at least you get somebody for a few years, not just that year of students coming through. And so actually the RSM does run a kind of teachers and careers officers kind of day in central London, which I've spoken on before. But yeah, I think that's a really good idea from the educational point of view, because you help them and they can support subsequent generations of students.
Okay, thank you. So a little technical hitch earlier, but it's a bit behind time, so we need to move on to the final talk. Thank you, Kevin. So the final talk is Aloysius Chow, Preparedness for Practice of Final Year Medical Students Survey Data Findings.
Thank you. Hi. I know most of us are hungry. I'm just going to move on. And some background info about what we're trying to do. So there's growing international literature about concerns whether medical graduates are prepared for practice. And the literature has been published from countries like the UK, Croatia, Australia, Malaysia. And this growing concerns is not just by professionals, but also from students. And that's one of the reasons why we were driven to better understand whether our graduates were prepared. So some of the areas that students report being especially not prepared or less prepared would be emergency management, safe prescription, understanding ethical and legal issues, as well as end-of-life care. Now, the third point on the screen you can see is something that we'll come back to later on as I talk about the results. So it's about the Student Assistantship Program. And this is part of the MBPS program here. And it's been designed to help students be more prepared. Yeah? And when this happens is during the last 10 weeks of the program, and it occurs after the final examinations, and students then join care teams and are supervised by senior doctors. And the students here will then gain experience in key specialties such as internal medicine, family medicine, general surgery, and orthopedic surgery. Now, the aim of our study really is to explore, as I mentioned just now, levels of preparedness for practice of our first cohort of LKC medical graduates. And how we do it, or how we did this, was to administer questionnaires. These were online questionnaires that the students had to complete at 3 time points, and I'll share with you when later, as well as interviews, right, with the students as well as the clinical posting supervisors. So this was all done, right, the questionnaires were done before and after the Student Assistantship Program, right, the SAP, as well as during the first posting of their postgraduate year 1. Just to illustrate that in a bit, right, the questionnaires that we use have been designed, and there are questionnaires designed and validated in this area. And one of the questionnaires, or rather the questionnaire that we use, right, I'll share with you a little bit more later, but it's a questionnaire that was administered in a study run at Newcastle University. So anyway, these were 3 time points where we administered the questionnaire, and for today's presentation, I'll share a bit more about the results from these 2 questionnaires here. And the questionnaires really were looking at 3 key domains, namely preparedness for practice, readiness to respond in an acute care situation, as well as clinical experiences afforded by the students. So who are our students? This is it. They were mainly, most were male, they were predominantly Chinese, and age range between 23 to 25. And again, just to remind you, the 3 key domains I mentioned just now: preparedness for clinical practice. Specifically, we're going to talk about procedures in clinical practice, experience of clinical practice, as well as readiness to respond in acute care. And just for your info, at the bottom, there's a short little footnote that we adopted a questionnaire by Dr. Brian Buffett and his colleagues. And this questionnaire was based on the learning outcomes from GMC's Tomorrow's Doctors. So we adopted the questionnaire and changed it a little bit. Yeah? And I'll share with you our results right now. Now, in the first domain, with regards to preparedness for clinical practice, there were 37 questions in the first section, and they were scored on a 5-point Likert scale. 1 being not prepared and 5 being fully prepared. And right at the bottom there, I've given you some samples, 3 questions that were, some of the questions that were asked, or the students had to answer. So looking at these 37 such items, the mean score for pre-SAP was about 3.5, and post-SAP, the scores were significantly increased. And we can see that the range increased as well after SAP. So breaking these 37 items down, we looked at the top 5 and the bottom 5 items, and these were the top 5 items. So pre-SAP, the scores were fairly high, above 4, and after SAP, the scores increased as well. Now the bottom 5 areas, as you can see before SAP, range from 2.4 to 3, but after SAP, all of them increased. And again, this was significantly, they were statistically significant. So we could infer that SAP did help students increase their preparedness in these areas. So now going on to the second domain, clinical experience. So this was one of the questions asked in the questionnaire, and in essence, it was asking how much experience or how many students had experience working with a junior doctor. And before SAP, about 28 of them said no. After SAP, that dropped to 2. So again, one can infer that this significant increase in number of students who had experience working with a junior doctor was aided by the SAP. So the next bunch of questions, right? Students were asked to agree, right, with these statements. And again, before SAP, the scores were between 2.6 to 3.6. Yeah? But after SAP, again, we see a significant increase here, statistically significant increase. And again, the inference here is SAP did give them the ample amount of experience, right, for clinical practice, clinical opportunities in these areas. Now, moving on to another kind of experience, we're talking about hands-on experience here. And these are the 4 options that the students were given when they were answering the questionnaire. So on the left, right, you see not seen and observer, those are more passive roles. And on the right, participant and lead, these are more active roles in certain situations. So before SAP, right, is the middle column, right? So these were percentages of students who led or participated, meaning they had a more active role in these situations. And sepsis, asthma, right at the top, and we had about 50%, 51% of students who were actively participated or led in these acute care situations. But the interesting finding for us here was the right column. These increases were all statistically significant, meaning the SAP provided students with experience and exposure to these acute care situations, and that helped them get the experience I was mentioning just now. So more about hands-on opportunities. So students were asked, have they had hands-on experience in dealing with a real-life medical emergency? So before SAP, 24% of them said no. After SAP, that dropped down to 11%. Students also had to go through these acute care simulation sessions. And again, before SAP, 20% of the students said no, they didn't have such an experience. But after SAP, only 2% said so. Now, go on to the third domain, readiness to respond, to be a first respondent in acute care situations. So before SAP, right, we have diabetic ketoacidosis, sepsis, and acute coronary syndrome death. So before SAP, levels of readiness was about 3.5, but after SAP, that increased. And for the top two, diabetic ketoacidosis and sepsis, those increases were found to be statistically significant. Now for the bottom three areas, adverse drug reaction, paracetamol OD, and stroke. So before SAP, the scores were between 2.7 to 3.2. After SAP, we found them to have increased as well. So adverse drug reaction was the one that was significant, statistically significant. So just to sum this up, the findings here showed us that the SAP, the Student Assistantship Program, appeared to help students be prepared and ready for practice. And what we found specifically, right, was the students felt more prepared and ready in emergency management, right? And if you're going to break that down, specifically in handling diabetic ketoacidosis and sepsis, right, situations like that, as well as in areas like drugs and prescribing, specifically safe prescribing, calculating drug dosages, and managing adverse drug reactions, patient handover, and end-of-life care. Now, these were areas that were found to be difficult for students, or students found that they were not prepared in the literature. And seeing that the SAP helps students become more ready and more prepared in these areas is a pretty positive finding for us. Now, the next step for us, though, is not just to rely on these findings on these two questionnaires. Now, as you can see from this timeline over here, which I showed you earlier on, what I've added here are 4 new purple boxes, and these are the interviews, right, that was carried out in March with the students. The second interview carried out in August, still happening, and of course the third questionnaire. So what's happening for the 3 questionnaires is we'll be analyzing all 3 questionnaires in a longitudinal manner to find out more about the change that students have been experiencing. And of course, to inform the quantitative aspect of this analysis, we'll be looking at the interviews. So not just the student interviews, but also the interviews with the clinical supervisors. And we hope to, well, eventually we will want to integrate these findings and look at the results cross-sectionally and longitudinally to find out what really is happening for the change. So with that, I'd like to end my presentation. Thank you very much.
Okay, so we have run a little over, but in the interest of